Welcome to another episode of Health Matters with PA Lynn Szabo. I'm Heather, and what are we going to talk about today, Lynn?
I think there's some shifts in the community about chronic pain management, and I don't really want to address those directly, but I want to bring around the concept of a chronic pain toolkit and how people should manage their chronic pain, because it's going to be less and less that the doctor's in charge of it and more that the patient's in charge of it. And
Wait, like we get to write our own prescriptions?
No, not that much.
Not that much in charge?
But the things that somebody does to manage their chronic pain is going to be more patient-driven and less provider-driven. There'll still be a role for a provider for prescriptions and things, but they're not going to be the focus anymore like they were. And so in particular, chronic pain treatment is no longer opiate-based.
Oh.
So that surprises people.
Wait, you like long-term chronic pain?
Mm-hmm.
Okay.
Like there's no indication for, let's say if somebody has osteoarthritis, let's say it's specifically in their neck, that opioids are no longer indicated for that pain problem.
But isn't it kind of dangerous to take opioids for chronic pain management?
Yeah, it is. And a lot of people got given them. Like 10 years ago, it was a different world. It was like we have to treat people's pain. And now we're, as providers, we still believe that we need to treat people's pain, but we have 10 other ways we can do it. And so we're going to do it the safest way, the one that makes the most sense. And for people whose receptors in their brain are conditioned to needing an opioid stimulus in order to feel like they're not in pain anymore. So, so what that is kind of treating chronic pain that's due to absence of opioid with opioid. We're not in that circle anymore, and that's going to frustrate a lot of people.
Yeah, I bet it will.
So there's going to be more medications, other medications like antidepressants and anti-seizure drugs, but the majority of chronic pain modalities are going to be patient-driven. So if somebody has a chronic pain problem, then what they need is, like any problem in life, you need to kind of get your resources together and make sure you have plenty of resources to address what is a big problem for people. It can really change the way their life is. And so when I'm sitting in the exam room and I'm talking about this, I'm saying, look, here's your chronic pain kit, okay? These are the resources that you can use to to control or manage your pain. There's like 20 things. Do you see that only 3 of them I'm involved in? Oh. That's what I mean.
Okay.
It's a huge, big change. So at any one time, a patient's going to be, they probably internalize it in their brain, but you could write it down. But any one time, you're going to say, I'm going to use combinations of this, this, and this, and it's not going to be a focus on one pill. Okay. So I don't think patients get this, although I've been talking about this for like 15 years. It's not the news they want.
It's really not. And we've talked about a little bit about this too, about that I have chronic pain. I've trigeminal neuralgia, and then I have a severe knee injury. But I was never managed chronically with opioids, ever.
Right. So I don't know the timing of all that, but 10 or 15 years ago, what we were hearing, and they stopped all the appointments in the open door system for an entire day, and they put all the providers in one room and they had speakers. And what they hammered home was people shouldn't be in pain. You have to give them pain medicine. It has to be opioids. Don't
oh my gosh!
Don't mess with them.
Is that part of the Sackler? I had no idea.
Yeah,
that was part of the Sackler
that
sediment.
Was part of the
that
marketing.
Okay.
I'm certain that it had something to do with the marketing of OxyContin at the time.
Oh wow!
And there were a lot of providers in the open door system sitting there going, "I'm not doing that." That's where the pain. Just as an interesting aside, the pain scale, and the thought that it's like the 5th vital sign or something like that.
It never made sense to me.
We never, the medical assistants and the nurses are always, yeah, her pain's at a 6. That's like in one ear and out the other as far as I'm concerned, because how can you know that's true? And how can you understand that? What does a 6 mean?
Right? I've never understood the pain scale, to be honest with you.
Yeah. So
I can function or I can't function.
that
It
was
hurts really bad, but I can still stand
that
up.
showed up with the Sacklers. That was part of the OxyContin thing.
Oh.
So, but it's still there, and it's still a billable point. So you have to get a certain number of patients have to have record in the chart that their pain was addressed in that manner, which is not at all a good manner to address pain. Some people are at an 8 and they're entirely functional. Some people are at a 2 and they're falling apart. So for me, it's meaningless, and I ignore it 100% of the time. So this is going to be really hard on people who previously were only using opioids, because their experience of pain in their brain has changed, and it's changed in a permanent way. And they're going to feel pain more intensely because of the changes the opioids provided, and they're going to be more likely to see opioids as the only solution for their pain. And what they don't get is, okay, so you take an OxyContin, and then what happens 4 hours later? Oh, you take an OxyContin, and then what happens 4 hours later? So maybe it works, but it's so limiting, Maybe you got to take your OxyContin 3 hours later because it's starting to not work as well, or you got to have a higher dose, or you have to have a more sustained dose. And then we have people going to the streets for pain meds. Wow.
So is that physical addiction, or is that you're changing the
both.
Structure of your brain
It's
so that
both.
pain... Well, that was loud.
Yeah.
Changing the structure of your brain to where pain feels more intense.
Pain feels more intense. So we used to say if somebody was taking, that people could take chronic narcotics and not, quote unquote, be addicted. But they do get addicted. They get physiologically addicted, and then after a while they get psychologically addicted.
Okay, so it's like a dual addiction.
Yeah. We're 100%, we were marketed to at the time. It's like, I don't know, 15 or 20 years ago. And, we were telling people what the drug company wanted us to tell them. Not everybody. There were some providers who never bought into it. But there were some that bought into it in a big way.
Well, I know when I had my knee surgery, and they did all of that work on it, and I was non-weight bearing for 6 to 8 months and couldn't walk for over a year and had to learn to do that again. I was given the largest bottle of OxyContin I've ever seen in my life.
Right.
And it was supposed to last me for 3 months from healing from the surgery, but it had no effect on me. I might as well have eaten Pez. I was in so much pain from that. Right. I was so uncomfortable. I was throwing up, and the OxyContins did nothing for me. So when I did my follow-up surgery, I actually gave them back and was just like, you prescribed me Pez. What is this stuff? I'd never heard of it before.
Right.
And he laughed in my face and was just like, you could sell those on the street. And I was like 25 then, so this was 25, 30 years ago.
Right.
I don't. So is that?
I think the mistake there is, so chronic pain is anything that lasts over, well, it depends who you ask, but anything that lasts over, let's say, 6 to 8 weeks.
Okay.
So you actually did have a chronic pain problem. You had acute on chronic, and what they needed to do was give you more than one tool to deal with it. And so what I'm seeing, not having reviewed,
That's exactly what he
right.
did. He sent me home with this ice chest thing that circulated cold water over the top of my knee, and I didn't take pain medication anymore after that. That was sufficient.
Exactly. But I think somebody with a chronic pain problem needs like 20 of those. I mean, not necessarily that specific item, but 20 different ways of looking at it. And most of them are not provider involved. And most of them are difficult to do for somebody in chronic pain. And they get written off like immediately. Like, that's not going to do anything. Like, oftentimes people say, I had this pain problem, I went to the ER and they didn't do anything for me. And I'll say, well, I'm looking at your discharge summary and they prescribed you ibuprofen and Tylenol. those are pain medicine.
Yes, they are. And they're very effective.
And they are very effective, and you can't say that's nothing, especially if you haven't tried it.
Yeah.
And you also can't take more than what's prescribed and think somehow it's going to work better, because it's not. Oftentimes people will tell us that they're allergic to Tylenol and they want Vicodin, but Vicodin's got
Tylenol in it, right?
Tylenol in it. So, we're rolling our eyes. Or during the time, people on Medi-Cal could only get Vicodin if they were allergic to Tylenol with codeine. And so the whole town was like simultaneously allergic to Tylenol with codeine. And then they cut the Vicodin out, and people had to circle back around and say, well, I don't know how that got on my chart. It's like, the thought is we've never seen that, people saying this before, but there's a bunch of ruses that are pretty common. But that only reflects back that the desperation that people are in, I think.
Yeah, pain sucks.
Yeah, they're really trying to manipulate the situation. So chronic pain toolkit is something a patient needs to sit down with their primary care person and try and maximize their resources. It is a long, involved conversation. Usually makes people angry. And it oftentimes doesn't happen because, remember, you have an average of about 7.5 minutes in the room with them.
Man.
So it's really hard I usually write it on, this is your toolkit. I usually write it on table paper, and they usually tear it off and take it home. Although some of them reject it outright. And all they want is the opioid.
It would make sense when you're in pain and you're that frustrated and you
Right.
can't function and keep your job and take care of yourself and your house and your kids.
Right.
And you think there's this magic pill that will solve it. But
Right.
it doesn't solve it.
It doesn't solve it. It oftentimes leads to more problems. And to bypass, if you had a big problem in life, like you were going to build a house, do you really think you're going to do the whole house with just a hammer?
No.
That means you don't have nails, you don't have lumber, you don't have concrete, you don't have a ladder.
Yeah, no electricity.
Yeah, it's kind of ridiculous.
There's no cable.
Exactly. And actually, not to be, this is another digression, but you can get 30% out of placebo. And better is better. So,
and that better is better, whether it's a bath or it's
right.
lighting a candle and saying a prayer. I agree 100%.
So these are some things that could be in a chronic pain kit. So non-steroidal anti-inflammatories, that's our friend ibuprofen. Remember, ibuprofen equals naproxen equals, there's another one I'm forgetting.
Motrin.
Motrin, Advil, they're all the same. Pick one. And dose appropriately. So a lot of people will, with non-steroidal anti-inflammatories, you really have to take a grown-up dose at a regular period of time. And these are all calculated out scientifically. So if you take 100 milligrams, which is a baby dose, is an infant dose, and you take it, every other day, and it's not helping your pain.
That's why,
because you're trying to accomplish something with homeopathy, and that doesn't usually work super well. So get on adult doses and therapeutically dosed appropriately. Tylenol, which is also known as acetaminophen, that's important. But with both of these categories of drugs, you can take too much. So if you are taking the recommended dose at the recommended time and it's still not helping you, the answer is not to take more, because that's going to take your liver out in the case of Tylenol. It's going to take your kidneys out in the case of non-steroidal anti-inflammatories. So at this point, you have to be looking through your toolkit with the intent of using maybe 2 or 3 things for any particular pain presentation.
What is the, because I try rarely to ever take Tylenol because I'm afraid of the liver toxicity thing. What is the safe manner to do both ibuprofen and acetaminophen? What is it, 6 hours you take this one and 4 hours you take this one?
You probably ought to ask your provider about that, but in general, otherwise healthy person who's got good liver, good kidneys, they can take 600 milligrams of ibuprofen 3 times a day So 3 times within 24 hours, and then Tylenol at the same time, because they're 2 different drugs. You can take 1,000 milligrams 3 times a day.
So you don't have to stagger them.
No, you don't. That is the most you can take, but each pill that's bought over the counter is like a mini M&M. Okay, so you're looking down at your hand and you're seeing a lot of M&Ms, but remember there are a lot of mini M&Ms.
Okay.
Okay.
So if it's prescribed to you, so if you have a prescription, those ones are stronger than the ones we buy over the counter, correct? The one, like one pill of a prescription is
Yeah,
like
prescription
600
is
milligrams.
usually stronger than the ones over the counter.
Okay, so just be very careful what you're doing.
Right, and that's a good point, because I kind of think that the way medicine in general is going, they're going to put the responsibility more on the patient. Like some meds aren't going to be covered, and they're going to have to be dosing per their doctor, and not necessarily they're using their mini M&Ms the way their doctor directs, not necessarily the way the bottle does.
Okay.
And then rest is an important one. Heat and ice. I prefer ice because heat makes you feel better in the moment, but kind of kicks the can down the road, so you feel worse in the long run. So ice is like 3 minutes of going, why do I have an ice pack on my neck? Because like, this is a stupid idea, but okay, after 3 minutes, it kind of eases up. Topicals like lidocaine patches, diclofenac gel, which goes by the brand name Voltaren, but also over-the-counter topicals like Bengay, Tiger Balm, and for the Native community, the elders, especially of frosty arthritis, get a lot of benefit out of wormwood. Okay. And they always know somebody that makes good wormwood. You know, somebody's niece makes especially good wormwood, and so topicals like that. You know, this might be a good point to talk about topicals like that have THC in them, or CBD.
Yeah.
Topicals. That's kind of a medicine doesn't really have the data that they need to give their blessing to it for the most part. Most of the doctors who go along with it because they don't think it's going to hurt somebody. But here's a way it could hurt somebody. If somebody also maybe gets 30 Vicodin a month and according to the clinic protocol, gets urine tox screens, we usually do them about every 3 months. If that THC shows up in a tox screen at a federally funded clinic, then most providers will see that as a reason to stop the opioid.
Is that so they don't lose their license or their funding, their federal funding?
Yeah. It's because it's
for legal reasons.
Against the law on a federal level.
Gotcha.
And so that becomes a huge problem because it doesn't move out of, the byproducts don't move out of the urine very quickly. Okay. So I think it takes like a month to get rid of it.
Even using it topically, those creams, you're going to absorb it into your system.
You do.
Okay.
Mm-hmm. You'll get enough. Those urine tox screens are really, really sensitive and specific. And so mostly what patients do is all of a sudden they can't pee and they want to take the cup home. You are fooling nobody.
Yeah.
You're fooling nobody. So, just
nice try though.
Be mindful of that. People really like it and they do feel better. And it will help them with sleep and stuff, but there's a lot of downside to those products, not necessarily topicals, but also gummies and stuff. So be mindful there's a give and take there.
Okay.
Exercise. Now,
how do you exercise when you have chronic pain?
Well, the endorphins kick in after a while.
So force of will to get yourself up moving till you get endorphins kicking in.
Right. And there's different forms of exercise that maybe that person with, chronic knee pain is not a jazzercise kind of person.
So if we're just looking for the endorphins in exercise, that would count sex, right?
They're amazing. And you could go to the pool. If you're saying, look, my knees really hurt and that's why I can't walk around the track or something, then I would say, let me tell you about Wednesday night. It's UIHS only night, and it's free to go do your workout there.
The pool's amazing. My mom was severely disabled and had physical chronic pain. She had Charcot-Marie tooth, so her feet would break when she walked. She had really bad arthritis, and she loved the pool. just spending 20 or 30 minutes in the pool where she could move without pain changed her outlook. It affected
Right.
her mental state, her ability to communicate. I think that's something that we often
is
overlook,
amazing.
being able to move without pain.
Right. And I saw something on Facebook recently where somebody was saying my doctor didn't give me anything for pain. They told me to do yoga. Yoga is amazing for pain for the same reason. Same partial reason you get the endorphins going. The pool
Yeah.
is like a cold pack too.
Oh,
You get
that's
endorphins in it.
that's true.
To my feeling, it's a little on the cold side, and that always makes my joints happier. So do not diss yoga.
Yeah, gotcha.
Yeah, yoga for my recent operation, and my whole, because I have pain in my foot from my surgery, but I also am moving around through the world differently. Yoga has been like amazing for
Yeah,
me.
that year spent on crutches caused permanent nerve damage in my shoulder, which still doesn't hurt as bad as my knee does. But
Right.
you
Yeah.
move differently. You're going to affect different parts of your body.
And I'm using yoga mostly for sleep. So good quality sleep is important for pain control.
That's true.
Yeah. So people don't really think of that. When you're in pain, it's hard to sleep, and then you get grouchy and frustrated. But sleep can really help. So if somebody has sleep apnea, have that tended to. If somebody is not using good sleep hygiene, which I don't, but I watch Grey's Anatomy all night and kind of doze in and out of it. But be mindful of good sleep hygiene, because sleep is a treatment for pain. All of these are, and nobody's going to use one of them. They're going at any particular time. They're going to be using 3 to 4 of them.
That's true.
Yeah, and then chronic pain groups can be helpful. There's some probably going on at Del Norte Community Health Center. You have to get with the right group of people and a good facilitator.
Okay.
But they talk a little bit about journaling, which I think is helpful for some people. Would not work for me. But but maybe I shouldn't be, it's not my toolkit, I'll say. And also prayer. Prayer can be very helpful for the right person.
Yes, I
Yeah.
agree.
Yeah. Distraction. So for me, it's like at nighttime when I'm sitting in bed and I'm hurting and I'm frustrated, getting up and taking a warm shower, so that's distraction, is super helpful. Some people, and then there's a whole bunch of other things that we could do as providers. We can provide muscle relaxers, which mostly just make people sleepy, except for baclofen. Baclofen, it actually has more of a therapeutic, especially for nerve pain. Baclofen is helpful. And let's see, what else? There's certain anti-seizure medicines that help, especially with nerve pain.
Yeah, that's what I took, was the seizure medication and a blood pressure medication to stop it pressuring on the nerve.
Yeah, can be super helpful. Now, does that mean when the first day you take the pill and you're still hurting 10 minutes later that's not working?
No.
That means you be patient and you get up to a therapeutic dose and you work on it for a time and see how it goes.
Well, I think there's also has to be a realistic expectation too, when you have chronic pain, that's yours now.
Yeah.
That's just yours. The same way anybody else has to deal with depression or other types of mental illness or anything else, you have to find ways to accept that not every day you're going to feel 100%.
Right.
Even with your therapeutic doses of non-opioids.
And then you choose how you want to get through that day, even when it's crappy.
And I never understood the opioid thing anyway. We would never look at a 3-year-old and put them on OxyContin because they were in a car accident and they are bruised.
Right.
We don't do that to children, yet as adults, we expect if we have tooth pain or we cut our finger or if we break our leg or any of those other things that we should exist without any discomfort whatsoever. And yet we don't have that expectation for a 10-year-old or an 8-year-old. They got into the same
or
car
somebody
accident
else.
as you.
Or even somebody else.
Yeah, but God forbid we experience all of the sensations our body has.
Right.
And again, I live with chronic pain, and I've been in that position where I was at work and I had just decided that I would rather be dead than to live another day like this.
Right.
And then recognizing that wasn't appropriate, and calling my doctor and going in and finding
getting
those
help.
things. But again, opioids was never, thank God, ever looked at as a way of managing my chronic pain.
Right. Well, there's also a lot of other things like anti-seizure medicine. We talked about physical therapy, which is kind of in the yoga category, TENS unit.
Oh, I love those.
Surgery, antidepressants, Suboxone, which a lot of people are going to get switched to. So they help the brain's need to feel that specific opioid molecule without actually, downsides of, like, say, overdosing.
Oh, cool. That's cool.
Yeah. Acupuncture and acupressure, which are not very available up here, but are super helpful. So chronic pain tools are personalized. They're always changing. At any one time, the patient should have like absorbed like a mental list, or maybe written on the refrigerator on a piece of paper, and go, okay, today feels not so great. I'm going to do these 4 things. I'm headed for the pool. Losing weight, super important. And you might say, how are you going to lose weight when you can't exercise? Well, you got to exercise. I'm sorry, it makes you hurt.
Yeah. You have to keep moving or you're going to lose the ability to move, and it makes the pain worse.
Right. And endorphins are actually a lovely thing. They really are.
Yeah.
So you're going to have to work closely with your provider, and each chronic pain visit is going to have to be about something else besides refilling my oxys or refilling my Vicodin. You're not going to get it like you have in the past, and you have to. I have a lot of people approach me at parties and social stuff, and mostly they want to tell me how nobody understands their suffering and how all the doctors in town suck. Well, that's medicine is going to remind you have the tools to take care of this problem yourself for the most part. And we can help in a very limited way, but we're not going to be the whole story.
That makes perfect sense to me.
Yeah. And I think a lot of people are going to be thrown for a loop. They're going to feel really abandoned and angry. And I think some of that anger is justified because they got put on meds that
made their pain worse.
Yeah, that made their long-term life full of more agony.
Yeah.
And and now there's like a generation of people going through whose brains are really messed up with regard to opioids. And it is extremely sad, but there's some tough love is coming down. So
wow,
nobody can bail to a pain management practice and get refills like they used to. It's not going to work.
Yeah, when I was sent to the pain management in Eureka to see Dr. I'm going to say his name wrong, Dr. Jaworski. I remember he did injections into my neck.
Right, that's
and then
what they do.
For my knee, right, there was cortisone.
Right.
And then there was Synviscs, right, and then
Right.
just wait until it's completely shot and
Right.
absolutely unfunctionable,
Right.
and then get a knee replacement.
Right.
I mean, there's other options other than the opioids, which thank God I wasn't.
So chronic pain practices do not prescribe opioids anymore. And
Okay.
so people are going to be shocked to find that out.
Oh yeah.
And
I
also
bet.
Dr. Jaworski, a wonderful guy, was working out of Mad River, which is a hospital at risk from Trump's big ugly bill.
Oh crap.
So here we are in rural community needing these resources more than ever and having them threatened. But that might be the talk for next week.
Yeah, I think we do need to prepare and understand what it is that's going to take place as new bills are passed and our society takes this shift, and whether or not we want to take that shift and what we can do to stand up to it.
Yeah, the whole shift is more patient personal responsibility and patience to them that feels like they've been abandoned. It's really hard, but it's coming.
Wow.
So,
well, that was lovely. Thanks, Lynn, for leaving us on a depressing note.
yeah, I know. Votes matter, folks. Votes matter.
They really do.
Oh.
Okay, well, thank you for joining us today, Lynn. This was a very interesting topic.
Yeah.
If you'd like to listen to this episode again or any episode of Health Matters, you can always go to the KFUG YouTube channel and select the playlist and scroll through and find the topic that you want to hear again. Thank you very much. I'll see you next week.
Thanks.